welcome back. So this is the last bit of what has otherwise been a very interesting day. So this is just a panel discussion, which is, I suppose, just an extended Q&A. But the panelists this time are allowed to talk to each other as well. Extra frisson. I'm gonna again cheekily start this off with a question for everyone, which is, okay, so we've talked about kind of somewhat vaguely about different concepts of dying, right? And potentially, so my question is, what exactly are they? It seems reasonable to say that all humans are mortal, and so in some sense we're all dying, and that is independent, or like mind independent. It's a fact out in the world. You know, it's dependent on things other than our practical concerns and interests and values. But it seems equally plausible that there is a substantial difference between that sort of dying and the way in which someone with end-stage heart failure is dying. And I wonder what you think about that, whether that difference is just a practical concern. So the difference is entirely grounded in our values, concerns, and essentially our minds, or if there is genuinely some, mind-independent group of people who are dying, but not the whole of humanity. Does that make sense? Are there subsets of people who are dying in significantly different ways from the whole of mortal creatures? Stephen?
Yes.
Do you think that there is a substantial difference between, or the difference between the way in which we're all dying and the way in which someone with end-stage terminal cancer is dying is a kind of is a physical fact in the world difference, or is it actually just a question of our practical concerns and values, or is it,
I think what you're referring to is the distinction between senescence and eventually succumbing to the process of senescence and all of the various other ways by which your life could be ended. We know that organisms, so to speak, wear out with a couple of surprising exceptions, like the Hydra, that don't seem to senesce. But most organisms do, including us. And because of that, even if we were extraordinarily careful not to get hit by a bus and so forth, not to get a disease, we'd still eventually die because of that senescence. And then there are multiple other ways, of course, like you mentioned, heart attack, but also various ways that things like natural events can end a person's life. I'm not sure what you were getting at with respect to values, but that was my initial thought, given your question.
Yeah, I mean, I'll put it to the rest of the panel. To what extent is someone with terminal cancer with only days to live dying in a substantially different way from everybody else?
So it's an interesting distinction. When I first said I was going to go into palliative medicine as a specialty, a colleague seemed a little bit surprised, and he's a renal physician, and I said, we're all palliative, we just work on different timescales. And that's something that he sort of reflected a little bit on, slightly flippant, but sort of it relates a little bit to your point. It's interesting because if we are being pressed to highlight what it is that causes that distinction, it's hard. But I also have an idea of if I'm called to come and review somebody who the current clinical team think is dying, I have an idea of what that might look like, and I have an idea of what to expect, and I have an idea of what clinical situations I might be facing and needing to support in terms of physical symptoms, in terms of their psychological needs, in terms of their social needs. So there is a, pragmatically speaking, there is a concept, I think, that I have an idea of what I would expect if I'm going to be reviewing somebody who is dying, and maybe picking up on the term that Guy used, this idea of, is somebody dying or are they dying?
I guess that people can die. What it looks like to me looks different depending on what condition that they have, whether that is on the whole different from, because everybody in this room is going to probably die in one of those ways. I wouldn't say it's substantially different. I think the group that maybe I struggle with are these either sudden death ones, the suicides, or the death row, the ones that have been highlighted today by some of the philosophical talks. What dying, or when on their journey of life does dying start? I think that I grapple with more in terms of being a distinct experience than, I guess, the conditions that us as doctors generally see. I don't know if that kind of speaks to a little.
Yeah, I'm saying, okay, so you're a palliative care researcher. You want to do your research only on people who are dying. Why aren't you doing it on every mortal human? Like, because we're all dying. So you're taking some kind of subgroup there, and some palliative care research does mechanistic research, like assuming that there's a biological reason for subcategorizing. And I'm just asking whether or not you think that that's a valid thing to do.
I guess so when you were saying that, it made me think about how I was choosing who I was including in my current research, and I'm looking at prognostic conversations with people with heart failure. And, you know, all the guidelines, and it makes sense to me that sometimes you should be having conversations of what that person's future might look like at any stage, whether that's when they first had the diagnosis or further through their journey after they've been hospitalized once, twice, 3 times, or whatever. And actually the decisions I've made and the cutoffs that I've implied are purely practical. I can't go around recording absolutely every conversation that's happening with somebody with heart failure. So I've had to impose limits purely for practical reasons. So I guess on that basis, and your question, is it just a practical distinction? Maybe it is.
So I think sometimes I think about, is there a distinct population? And I was thinking, sometimes I use the phrase, someone says, are they dying? And I'll say, I don't think they're dying, but they've lost the ability to sustain their own life. So something about their physiological, psychological makeup has moved to the point where they're irreversibly unable to sustain their own living without external help. And so maybe that feels like a mind-independent property change. So the vast population can sustain their own life. We can eat and drink and we can meet our own needs, but then there's another cohort who now can't. And so without artificial, before modern medicine and before care, they would have died. That feels like a mind-independent change in terms of no longer able to eat or drink for themselves. So without external, that's a change in their status. So potentially there's something there. And then I also think there is something in the very last hours of life that is mind independently different. Maybe not 2 days out, 3 days out, like you were suggesting, but in the very last hours. It's the instinct is you walk into the room and you just know. And you spent a few days going, are they dying? Aren't they dying? Are they going to die today? Not sure. And then you walk into a room and you're like, it's going to be now. It's going to be in the next. And it's not, or not everyone goes through that, but sometimes you just walk in the room and you just know, and maybe that's picking something up. And it's, I would say to families, you won't know what I'm talking about. If you're thinking, are they going to die in short order? They'll say, if you're looking at them and you're not sure, probably not. But when they are, you'll look at them and you'll know. And the families will then come back later and say, I didn't know what you were on about at the time, but now after the death, now I know what you were trying to tell us. So whether that captures something, a process, two thoughts, whether they cohere, I don't know, but sort of thinking of things that might be independent of mind.
Yeah, let's.
Just that was just off the back of what you've just said. So then, in a way, differentiating between what I see as those three main groups. So fully independent, able to maintain their own life, no longer able to sustain their own life, and then dying. It seems like there's, as various speakers have spoken about, two main factors: a temporal kind of time factor, but then also a kind of a functionality factor. And do you think that at varying points along those different progressions from group to group to group, the time and the functionality have varying contributors? So do you think that transition from fully independent to no longer able to really sustain your own life is more of a functional change, and then when you're dying, it's more of a time-based factor? That's just my interpretation of what you've just said, and I just wonder whether that kind of feeds into your original question of, is there a significant difference between the groups, and how do we differentiate between those groups? Could it be that we come up with some ways of categorizing based off of temporality versus functionality?
I think I'd probably base it skewed heavily towards the functionality and something about an irreversible loss of that functionality. I think I'd want to build that in. This is me thinking on the hoof here. I think the time side of things is timescales are different for different people, and so possibly unreliable. But yeah, something about functionality. It's a change in their function. Maybe that's how you differentiate the groups. Whether it's a useful differentiation is another question, but.
I just to expand on that a little, I think you've talked about time, and I think progressiveness is a concept of that as well. Some illnesses, some events will cause a sudden significant loss of function that then remains stable. So, for example, a stroke that means a person can't swallow but can be fed through a peg, and therefore remains dependent on a level of medical intervention, but actually then reaching a point of stability, you wouldn't say that that person was dying. So I think there is that context, that pattern of where what is happening, it is time dependent, and there is a sense of a progressiveness. Again, I'm thinking on the hoof a little, but that's, yeah.
I wanted, there's also, isn't there a thing that with most palliative patients, you know what they're dying of. I don't think we know what we're dying of yet. But I want to ask a completely different question, if I could, to Steve, about relating your thinkers versus, I'm going to get this all wrong, I'm not a philosopher, but the animal versus the thinker, relating to brain death and our definitions of that, because I spend a lot of time sort of worrying about this, and it feels to me in our definition of, our sort of legal definition of death, or our medical definition of death, that we slightly mix up the groups, and that we have two, we talk about the permanent loss of the ability for consciousness and the permanent loss of the ability to breathe as our two criteria. And one of those, the breathing one, feels very animalism to me, whereas the other one feels very thinkism. And they're both, I mean, obviously on a ventilator, we can keep them both, or we can keep one of them going a long time, but we talk about the death of the person, presumably referring to the thinker or the mind. But yet we keep this breathing thing in there, which always feels a bit sort of random to me, and a bit animalism-y. That's terribly put, but do you get what I mean?
Yes, I do. Yeah, it was one of the things I was emphasizing that, depending on whether you adopt the animalist view or one of the thinker views, death is just gonna occur under different circumstances at different times. They're not necessarily going to coincide. Take the case of, you mentioned brain death, but start with the case of persistent vegetation. That's a pretty clear case of an animal persisting, not being dead. But on either version of the thinker view, the person has ceased to exist. If you accept my definition, that means that a person has died or a mind has died, and you're now waiting for the animal to die. And that seems pretty inescapable if you adopt either one of the thinker views. If you adopt the animalist view, you're just not going to believe in the existence of the thinker as an essential object. You're not going to accept that way of understanding any object. It's just you reject it altogether. So there's really, for death to occur, you have to wait for the animal to die. So those come apart. It's true. I'll leave it at that.
Thank you.
So I suppose I am reluctant to subscribe to any concept of dying which relies heavily on functionality or the loss of functionality, because I worry that some of that is due to the inherent ableism in how we operate medicine, and that it would exclude a reliable concept of dying for people whom their original level of function was not very good. I think that dying is a useful concept for people who have lifelong disabilities in the same way that it would be for people who were, who have seen a significant decline in their function. And so my concern is that whatever concept we want to use needs to be inclusive of people who who are have a medical complexity, disabled, learning disability, all these other things that mean that their sort of the standard view of functionality may not be their kind of their baseline, because I still think it's helpful in those patients to have a concept of dying. I'm much more inclined towards dying as a kind of intuitive human relational kind of experience, that there's something that changes in the way that we have relationships with people when they're dying, and that is kind of a bit more and I think that taps into what you say about when you walk into a room and you know that someone is dying, there's a distinct change in the relationship that you have with them, and so that would, I guess, yeah, I would be really cautious of anything that looks at functionality as a key part of the diagnosis of dying.
So I'm minded to agree with you on that. I think for me, so that was an exercise in how you separate the general population with maybe the population of interest. But I agree with you around the worries around functionality. And for me, I think a definition of dying is always going to be highly contextual. I think I'm going to struggle to come up with a broad one. So I think it will be highly contextual. And I think it's worth saying, with that differentiation between the two populations, it might be possible to do it, but whether that's useful or fair or helpful in the social world we live in, that's a follow-on question.
I would, one of the things that you said that I would echo, one of the things that came out of today, which was really interesting, was Professor Housekeller's talk. One of the things that resonated was about how people interact with other people, and sort of some discussion of being able to partake in what has been their sort of normal life and how they interact with people. And I've been reflecting with my palliative care colleagues that one of the things that we find ourselves doing in palliative care is trying to bring small normalities into people's lives. And we spend a lot of time and effort on this. And I thought that really distilled it down for me as to why we do that. Simple things like helping a family organizer, watching a film together with a pizza all in the room, just those things that we spend so much time and effort on. And it, to my mind, speaks to that, an element of that hope as well, of retaining those little normal things. Yeah.
We have a couple questions online. So the first one is, within a definition of dying, is there something around probability of dying in any month, week, day, hour, gradually increasing in life and in an accelerated way in a progressive medical condition?
And I guess that speaks to the presentation on prognosis, that the probability is probably changing constantly, and that there would seem to be some sort of threshold that would tip you over into, I guess, what the mass population would consider as dying or not. But it's not clear what that threshold is, and it's not necessarily 50% at all. Increasing in life, and whether that changes. And I guess that probability can go up and down depending on what condition you have, because it's not always linear.
Hi, Andrew Leach, another intensivist. I quite like the relational concept of it. It takes us back to one of the earlier presentations about talking about the loneliness of death and the loss, the sense of alienation from the world, and a sort of, I suppose, a sense of disintegration in personhood, being in anticipation of death. Maybe that's something you could recognize as a dying process. And it brings to mind a talk I attended at Putney, the Royal National Hospital for Neurodisability, by their chaplain, who showed us a series of photos of tombstones of patients who died in their institution. And these were patients with prolonged disorders of consciousness, so in persistent vegetative state or minimally conscious state. And most of those tombstones had 2 dates on them, which I thought was really, really interesting. So the first date was the date of their initial accident, and was often titled with something like, you know, lost to us on such and such a date. And the second date was the date of their physical death, organism death, 2 or 3 years later, when left this world on this date. So there's something about death and dying being related to what we mean by living. And again, what we value in life. And I think that varies enormously between different people and their relatives as well.
I find it interesting that people put that point in terms of relations among persons, whereas I think I would have conceptualized personhood in terms of self-awareness. At least in the tradition of philosophy, that's a pretty typical move. Going all the way back to John Locke, actually. But that kind of an awareness also makes it possible to be aware of others and the interaction between, and awareness of someone else's awareness of you, and the multiple ways that can be brought into play. But all that will go away if awareness is lost. And that's all possible while leaving behind the animal. Which makes it confusing, right? Because if you consider the person part as a kind of death, then you have to assume that there's another kind of a death that has not yet happened in the case of someone, an individual who's a victim of persistent vegetation.
Yeah, so there's something that struck me as a potential limitation of the relational, interpersonal view of dying, is that it doesn't seem to be able to account for situations where, for instance, someone has cancer and refuses to reveal it to anyone else around them. And everyone just continues, everyone in their lives continues to treat them exactly the same as if they did not have cancer. And that might even be a motivation for that person to choose not to reveal that they have cancer. And then there's an interesting moment that can happen where the person does eventually pass away, and then the people in their lives look back and realize, oh, this person was dying. But we treated them exactly the same way as if they weren't. And that this comes as a shock to the people who find this out about the person afterwards. So to me, what this indicates is that we can't just use the interrelational view as, at least it's very unintuitive to us in regular situations like the one that I just described, that the interrelational view of dying captures every aspect of what we think dying is. And the other thing that it indicates to me is that usually when that interrelational aspect of when the relationship between us and a dying person changes, for instance, what usually is at the basis for that change, for that shift in the relationship, is something that's happening at the physiological level of that person. So for instance, someone who had cancer, if they chose to reveal that to us, reveal this physiological issue that they have, that might be the reason for why we begin to, shift our relationship towards this person. And it seems to explain why we, in a sense, why we do have these sort of shifts in our relations with people when we discover that they are dying. But that discovery seems to happen, that discovery seems to be of something that is at the physiological level. And this is related to another point that I had thought about regarding thinking of dying as a loss of function. I think I agree that there are potential dangers and pitfalls of thinking of dying simply as a loss of function. However, I also think that perhaps these pitfalls can be avoided if we complement the notion of a loss of function with the idea of a progressive loss of function over time. And this seems intuitive because it seems to account for the fact that it explains why we're surprised in cases where we find out in cases where there is no change in the relational aspect, but then we later find out that this person was in fact dying. It accounts for the what's happening at the physiological level that would explain our change of mind when we realize this person was in fact dying, without necessarily falling into the trap of, oh, there is like a baseline or threshold of a proper function that once you fall below that, then you're considered dying. It's more of, there's this idea of a progressive loss of function over time that might be indexed to the baseline being an individual's baseline function that they were sort of born with or sort of were able to maintain over a reasonable amount of time throughout their lives before they started dying.
Does anyone want to respond to any of that?
I'll make a quick comment about functionalism. It seems to me that, or sorry, I meant ableism. I think that concern occurs due to worries about injustice and discriminating against certain persons because of their differing abilities in ways that really are unjustified. And I think that you can distinguish that whole worry from setting out certain kinds of definitions that involve capacities. And it does seem to me that in many cases, when we define key notions, capacities really are clearly determinative of whether the term applies. And it's almost certainly going to work out in the case of dying and death. You can surely, well, I guess I would argue that dying is the loss of certain kinds of capacities. And that's that kind of a claim, as far as I can tell, it doesn't get you in any kind of danger of injustice. I'll leave it at that.
Sorry, everybody, I need to leave. It's been really interesting, really enjoyed it.
While we let Paul go, we're going to listen. Elderline, do you want to make a final comment? I know you've been keen. Hand in the corner. Obviously, the speakers make the final comment.
The penultimate comment.
I think.
Yeah, I need to curb my inner Hermione Granger. Yeah, okay. So I like I've said before, I think it's helpful, so Arjun, you kept asking about mind independence. I mean, set aside words about mind independence. We could certainly ask about the biology of this in elephant, dogs, octopi, all those places where you don't have to worry about complex social structures, technological interventions, et cetera, and strike me as a helpful exercise. And you probably still end up, I watched my dog die, with your dying versus dying. Like, I remember when my dog was definitely in the last bit as opposed to the weeks before. But of course, one thing that happens there is that, organisms are self-stabilizing metabolic units, and as such, they sort of have tipping points. And once that tipping point is reached, whatever it is, it can't eat, it can't hunt, not well enough, pretty quickly, so you would see kinks in your curve. And of course, what we do, and sometimes you can just predict the kink, like that was the elephant's last molar, like it might otherwise be well, but from that point, it's just gonna kink pretty quickly. Because one of the things we do as humans extraordinarily is we reverse and smooth and that kink. But I think you can get a view of dying and stuff from animals. It's not going to get you that far for the case where we throw all of our heavy technology at it so that we get those curves of the heart patient, who goes like this and stuff like that. On the social side, I was wondering, so once you go, put that aside and think more about the social, when do I go and this dying, this saying goodbye, you're not described as fighting for your life, but as dying. does the biology really matter all that much at all? So suppose, I'm going to do this annoying thing in philosophy called a thought experiment. Fill it in however you want, but suppose that instead of getting the like, oh, sorry, Elaine, you've got like stage 100 breast cancer, it's metastasized anywhere, I knew you felt fine, but you're going to be dead somewhere in the next 3 to 6 months. You get, oh, sorry, Elaine, there's an intergalactic drone with your name on it, and there's nothing we can do about it, but you're going to be dead in the next 3 to 6 months, right? In terms of the social role and the social adaptation, like, okay, I don't have to seek palliative care in a hospice, but I think in both cases, I'm sort of radically shifted being a midlife person into the dying social role. You know, what am I going to do with the next 3 to 6 months? How am I going to prepare my kids? What do I want for my future? Yeah, all of those kinds of things. So, I mean, is that, so that suggests that really, if you're thinking about all of those aspects, prognostication is relevant, but the biology of dying, what we share with animals and dogs and stuff, maybe not very, like you said, Arjun, often the social starts to float almost entirely free from the, you know, the biology you started with.
Yeah, but we're now moving on here. I don't know if there are final comments.
I mean, okay, so I think the question about whether or not there's a kind of biologically real subcategory, biologically real subcategories of dying versus whether or not subcategory or creating all of these different senses of dying is just a question of our practical concerns is kind of coming from this, the literature, which basically asks physicians to use physical markers in order to know whether someone is dying, or dying, or, you know, so and if we are expected to use physical characteristics, there is something about that which implies that at least those people think that there is a biologically real distinction to be made. So I'm just kind of thinking, you know, there isn't a lot of how do we go about doing this, right? How do we go about answering the question, what is dying? And to some extent, what we can do is we can look at what people do and then try and reverse engineer what they must think dying is in order to do that, right? So for people who will only tell their patients that they're dying if they have they've reached a certain kind of life expectancy, statistically or probabilistically, then surely they must think that dying is a certain temporal proximity to death or a certain risk of death. That you're kind of reverse engineering the concept. And similarly, from the guidelines which say these are the kind of physical characteristics that you need to look for, and if you find all of them, then you should, you know, refer these people to palliative care because they're probably going to die. Then the implication is that those people think that dying is some kind of physiological process, and this is exactly what it looks like. And these seem to be kind of quite distinct things. But what they have in common is they all seem to come out of a practical concern that in general, in medicine, we are not referring enough people to palliative care. It's a lot of the kind of questions around this and guidelines around this are supposed to increase the number of people that are recognized as dying. And so there's all of this kind of, is this just a practical concern that's driving this proliferation of concepts, or is it a genuine, you know, objective thing that we've just failed to recognize so far, I think. I don't know what you think.
don't know if I've got anything wise to add. But I think you're right. There is this concern that we're missing people clinically when we're working. We miss the opportunity to tell somebody that they're dying or that there's a chance that they are dying. And I guess we're all just clambering to find a way to assess that. And just by the nature of us being external, we have to be finding these things that we can observe and measure. But as I said, I think from doing this day and really reflecting about it, there definitely is something about knowing internally, or this idea of what you said, some people, when they lose their status as a father or they can't work in the way that they do, they enter this mindset of like, I'm dying. And other people are able to reframe themselves and find other meanings, and they're more likely to talk in a way that they're still living. And I think that's also, that has kind of fed into some of the talks today, is that it's this spectrum, and at what point does living occur? But that could be very different for different people, just depending on how they're thinking about their own life and what they're able to give back to it. And we kind of get sometimes caught up in, are we prolonging life or are we prolonging dying? And how do we use that language? Is it because we think dying is something different, which I think which is what we're all grappling with today?
Yeah, I think for me, it's with the PhD data behind me, it's going to come back round to that question of what do we need the definition for? What does it allow us to do? What are we trying to justify with it? So it's going to be a contextual thing for me rather than a categorizing thing if it's to have utility. But that's not to say that defining stuff has to have utility in itself. So yeah, I think that's my sense. And then I'm also worried that instead of defining dying, I've just introduced a concept of dying to everyone. And that's what people are going to take away.
I think that might be a good note to end on. So for those in the room, let's carry on if you fancy a discussion and a drink on the terrace outside the back of Somerset House. Say what? Okay, and then okay. But for now, let's thank our speakers. Let's thank Steve online and everyone who joined online. Speakers in the room.